Today's topic is a case discussion, a case with abdominal lump and pain. Actually, this is a practical class, the abdominal lump, which help you to know how to take the history and how to examine and what is the consequence of this patient. One patient admitted to our unit. She was referred from medicine unit. She was admitted for 2 to 3 days in medicine unit with acute abdominal pain. Then she came in gynae emergency, and then we take the history. Okay, can you hear me, please?
Yes, ma'am.
Okay. So this is the lady. We'll take history. Please listen to the history of the patient.
আচ্ছা, এখন তুমি কি সমস্যা নিয়ে আসছো? ব্যথা। কোথায় ব্যথা? কতদিন ধরে ব্যথা? ব্যথা 8 দিন তারপর ডাক্তার বলছিল জড়িত টিউমার আছে, এইভাবে জেলে যাবো। পরে আবার 1 সপ্তাহ ধরে ব্যথা, গরম কাটছে, করে মেডিসিন করতে দিচ্ছেন। মেডিসিনে কিছু করে বলছে যে পেটে টিউমার, তাই নিয়ে দিলাম। ওরা বলছে আলট্রাসাউন্ডের টিউমার। তোমার ব্যথাটা কতদিন ধরে বললাম? কতদিন? 8 মাস। আর এমনি একলাগার আজকে 1 সপ্তাহ। তাহলে 1 সপ্তাহ ধরে বেশি। আচ্ছা, ব্যথাটা কোথায় শুরু হয়, কোথায় যায় বলো তো? আচ্ছা, আচ্ছা, তোমার মাসিক কবে হয়েছে? তোমার বিয়ে হয়েছে কতদিন? ছেলে মেয়ে কিভাবে হয়েছে? আচ্ছা, তোমার ছোট বাচ্চার বয়স কত? আচ্ছা, তোমার কোনো অপারেশন হয়েছে? 4 বছর আগে। আচ্ছা, তোমার আত্মীয় স্বজন কারোর মধ্যে এই টিউমার ছিল? তারপর বোন কারো এই ধরনের টিউমার ছিল? আচ্ছা, দেখি মা তোমাকে একটু। আমরা দেখি পেশেন্টের এক্সামিনেশন অন ইন্সপেকশন abdomen is bulging, distended, umbilicus center in position, there is a scar mark of previous appendicectomy, and on examination there is a mass about 24 week size uterus, and it is tender on palpation, and mass moves from side to side and also from above downwards, and surface is smooth, mobile, and আচ্ছা, এখন তুমি কি সমস্যা নিয়ে? And surface is smooth, mobile, and it is tender.
So after this history, you have listened the history, dear students. You have listened the history from patient. So what is our diagnosis? From this history, what is our diagnosis? This is a case of twisted ovarian tumor. Actually, this patient admitted with severe abdominal pain, and she was admitted in medicine unit, and there she was treated with analgesics and antibiotics, and then ultrasonography was done. Ultrasonography revealed abdominal tumor, and she was referred to Gynae department. After admission, we diagnosed the case as an ovarian tumor. It was a twisted ovarian tumor. So what will be our differential diagnosis? Our differential diagnosis will be fibroid uterus. Look at the picture. This is a case of ovarian tumor, fibroid uterus. And other differential diagnosis is endometriotic cyst. This is endometriotic cyst, and these are the chocolates which are coming from the after rupture of the cyst. In this type of tumor, if you can tell one or two differential diagnoses. But there are some also differential diagnoses which are written in book. These are the mesenteric cyst and other cyst, other like abdomen, pregnancy and full bladder. In case of pregnancy, if we do vaginal examination, look, this is the pregnant uterus, and vaginal by manual examination, this part would be soft. And there will be history of amenorrhea. Okay, there will be history of amenorrhea. And in case of full bladder, a patient may have a history of not evacuation. And this will not be for 8 to 9 months. This will be recent history. So we again can go to our slides. So differential diagnosis will be fibroid uterus. Examiner can ask you a question: how will you differentiate a fibroid uterus from ovarian tumor? If any diagnosis, will start from history. Ovarian tumor, the patient had a history of 8 to 9 months, and then she had sudden severe abdominal pain for 1 week. And in case of fibroid uterus, the tumor will be slow growing, and then examination, fibroid uterus will be palpation of it will be firm to hurt. And in case of ovarian tumor, it may be cystic on palpation. And in case of fibroid uterus, it will move from side to side, but not from above downwards. But in case of ovarian tumor, it will move from side to side and from also above downwards. If there is multiple fibroid in uterus, then surface will be irregular. But if a single ovarian cyst, the surface will be smooth and surface is regular. This is the picture of the endometriotic cyst. In some cases, also their differential diagnosis is written ovarian cyst as a ascites. In case of ovarian cyst, the cyst will be centered, and on palpation you can identify the surface margin of the cyst. And in case of ascites, abdomen will be transversely enlarged. And in case of ovarian cyst, that is like this. And on percussion note will be dull on the surface of the ovarian tumor. And in case of ascites, there will be shifting dullness, will be positive. You know how to deal with the shifting dullness. So these are the differential diagnoses of ovarian tumor. After abdominal examination, you have to do paravaginal examination, though you are not allowed to do paravaginal examination during your MBBS exam. But if we do paravaginal examination, if this is a ovarian tumor, if we do paravaginal examination, and this is uterus, and this is ovarian tumor. So during paravaginal examination, there will be cleft between uterus and ovarian tumor. And if we do bimanual examination, we will palpate the lump on the other hand through the abdomen, and also parvaginal hand with parvaginal hand. And in case of fibroid uterus, if you do by manual examination, one hand in the parvagina and other hand over the abdomen, you can palpate the lump with the uterus. If we move the uterus, it will move with the uterus. Okay, so this is how to differentiate from ovarian tumor and fibroid uterus parvaginally. Okay, understand? Now, how do you confirm your diagnosis? We have taken history from patient. One thing you remind that from during taking history, we also ask the patient for how long the symptoms, duration, how the pain was aggravated, and what was the relieving factor, and what was the aggravating factor. You have to ask this. And also, during examination, we have to palpate the lump, and we have to, during examination, we have to measure in centimeters. The lump have to measure in centimeter, length and breadth have to measure. In this case, as a 24-week size uterus, but during examination, you have to mention in centimeter. So we can confirm by history and also examination, for abdominal and for vaginal examination, and by also investigation, by doing the investigations. And what investigation will do for diagnosis? We'll do ultrasonography. A good ultrasonography can diagnose many things. Many things. I'll show you some pictures of ultrasonography, and then what are the other investigations you need to know for the patient's management? For patient's management, for operation, you have to do some routine investigations. What are these routine investigations? You know, at first, you have to tell serially. These are the investigations you have to see serially. Routine investigations are urine RME, routine microscopic examination to exclude if there is any infection, urinary infection or not. Then we have to do complete blood count or full blood count. If we say complete blood count, you have to not to mention the hemoglobin, ESR, TC, DC, all these. Complete, any picture of complete blood count, all the features are available. And then blood sugar. We have to do fasting and 2 hours after breakfast to exclude diabetes mellitus, because some of our patients are diagnosed as diabetes mellitus. If only RBS is done, it is not a good investigation. We have to do fasting blood sugar and 2 hours after 75 grams. Then blood grouping and RH factor, because patient may need blood transfusion. Then serum creatinine to know the status of the kidney, and have to do chest X-ray to exclude any chest infection or tuberculosis. And if the patient is more than 30 years, the patient will need ECG. So these are the routine investigation, and we also we have done an ultrasonography which revealed that the patient had ovarian tumor. So these are the routine investigations for the patient's management. And what are the other investigations? For rule out malignancy, we have to do some investigations such as C125, which will be raised in case of malignancy. And it also raised in some other condition. We'll talk about it later. And we can do MRI or CT scan. But these are not routinely done in every case of ovarian tumor. If we suspect malignancy or if there is query about the diagnosis, then we do these investigations. So how will we manage these patients? We have to do laparotomy. Before laparotomy, we have to counsel the patient about the operation, what will be done during the operation, what will be the after effect, and how long she have to stay in the hospital, other management. And in case of ovarian tumor, we have to give incision, longitudinal incision, longitudinal midline incision. In this patient, patient's ovarian tumor was like that. In this picture, she had several twisted ovarian tumor on the right side. This is the picture of twisted. And in case of twisted ovarian tumor, patients develop sudden severe abdominal pain. Why is twisting occur? Because if pedicle is long, it can move, and if there is space in abdominal cavity, it can move also. And if there is exercise or any movement of the patient, also can twisting occur. Twisted ovarian tumor occurs usually in case of dermoid or serous cystadenoma. Any question up to this? Dear students, during twisting, there is at first venous obstruction. Due to venous obstruction, the tumor becomes bluish, and then arterial obstruction. There is also blockage of the circulation, and tumor becomes blackish. And if obstruction is for prolonged time, it will gangrenous. This is a picture of twisted ovarian tumor. These are the twists. So after laparotomy, salpingioophorectomy was done in that case. Salpingioophorectomy, tubes and ovary was removed. This is called salpingioophorectomy. This is a picture how ovarian pedicle is formed in twisted ovarian tumor. This is uterus, and this is the healthy side, and this is the ovarian tumor. Pedicles forming the ovarian pedicles. How it is formed? It is formed by the laterally by ovarian ligament and the vessels containing in this here, and medially fallopian tube, ovarian ligaments and vessels, and laterally by broad ligament. These are the ovarian pedicles. This contains the ovarian pedicle. Then, what are the fate of the ovarian tumor, ovarian cyst? What are the fate? The ovarian tumor may twist, the cyst may twist, like in this case. There may be rupture of the cyst. If there is congestion and intercystic hemorrhage can occur, and also the rupture. Rupture due to ischemia may occur, or rupture can also due to parvaginal examination, forceful parvaginal examination. So we have to do parvaginal examination carefully, gentleness. And also, what are the fate? If ask you, then there may be also infection. Infection occur from here. There are the guards of small intestine and large intestine. So organism may come from here from blood vessels and lymphatic, and infection can occur. So these are the fate of ovarian cyst. This is the picture of this patient ovarian tumor. It was a twisted ovarian tumor, and surface was necrotic like this, and salpingioophorectomy was done. And so what was our final diagnosis? Final diagnosis of course, come after histopathology. So we see what is the histopathology report. it was serous cyst adenoma. That means it was a benign tumor. So up to this, our patient's history, operation, investigation, and final diagnosis. Then we will discuss something. This is a picture of ultrasonography. How looks how ultrasonography picture looks in different conditions. This is a picture of ovarian cyst unilocular. It is one locule. And this is a premenopausal lady. And this is the endometriotic cyst. It is ground glass appearance, like this. This is a picture of endometriotic cyst. And here also a ovarian cyst, but there is also solid component, unilocular with mixed echogenicity. Mixed echogenicity means there is also cystic component and also echogenic component and different type of echogenicity. This is homogeneous, but this is different echogenicity. It is a picture of dermoid. You know dermoid, what is dermoid? Dermoid is also a very common ovarian tumor which contains tissue from different mesenchymal origin. Ectoderm, mesoderm, and endodermal tissue can be here in dermoid cyst. This is also a common tumor in our practice. And this is a simple cyst with clear fluid. This is an unilocular cyst with clear margin. Unilocular anoikic, and it is less than 10 centimeter. It seems to be benign. This is the picture, probably benign. Ultrasonography can also detect benign from malignant ovarian tumor. This I have already mentioned. In malignant ovarian tumor, malignancy, where the malignancy occur. It can malignancy usually occur in extremes of age, but no age is immune for malignancy. And usually postmenopausal or postmenopausal lady with ascites, and in color Doppler, colors could be high, that is 3 or 4. And C125 is more than 100 unit in case of malignancy. One thing I have forgotten to say that in our patient, we also did C125. It was about 50 unit per ml, and so this is the picture of a benign cyst, and this is the malignant cyst. One thing, if you know this picture, is see this picture. This is malignant, and this is benign. Malignant for M and benign for M. 10 simple rules. Malignant or benign. Malignant tumor would be irregular solid tumor or be with mixed echogenicity. Hello? Can you hear me? Dear students, can you? হচ্ছে না তো আবার শেয়ার করতে হবে আমাকে Can you hear me? Can you see the picture? If you cannot hear, please tell me you are not hearing. I cannot see your message. So this is the rule, 10 simple rules. This is a slide how we differentiate from malignant and from benign by ultrasonography. In malignant tumor, is irregular tumor and it is solid and mixed, or maybe it may be solid or cystic mixed component. And in benign tumor, usually unilocular, no solid component. We have seen that in previous slide that this is a benign picture. This is simple cyst with unilocular cyst. And ascites found in case of malignancy. And that means fluid outside the tumor, and usually in pouch of Douglas. And there may be also some solid component in benign tumor, largest diameter of which is less than 7 millimeter. That is small component. And in case of malignant tumor, and at least 4 papillary structures may be present. And it is multilocular, solid, largest diameter is more than 10 centimeter usually. And in case of benign tumor, tumor usually less than 10 centimeter, there may be single or multilocular, but the septa will be thin in case of benign. And in case of malignancy, the septa will be thick and strong blood flow. If we do Doppler ultrasonography, it will show Doppler blood flow, color score 4. That means high blood flow in case of malignancy and no blood flow in case of benign cyst. So these are the 10 simple rules. 10 simple rules to rule out benign and malignant tumor. This is a tumor, mixed echogenicity. This is probably dermoid. And this is tumor, dermoid tumor. That is with mixed echogenicity. Some cystic component and some solid component. This is another picture. Echogenicity suggestive of tissue. This is a tumor and these are the cyst. And this is the solid component. It may be hemorrhagic cyst or other solid component. And this is the solid component, this is the solid component, but these are the cystic component. And this is a cyst, septum, means bilocular cyst, thin septum. So these are the some ultrasonograph picture of ovarian tumor. Sometimes there may be question, factors reducing the risk of ovarian tumor. What are the factors? If you know these factors, use of oral contraceptive pills or DMPA, because this will reduce the risk of ovarian tumor because there is anovulation. Ovarian pill, combined oral contraceptive pill will cause anovulation. And multiparity, because a long time she will be pregnant, so multiparity in many cases, and breastfeeding. Breastfeeding also suppresses the ovulation. These are the these are the protective factors. Pregnancy and ovulation. Here is a picture with hair follicle and hair. This is a tumor, dermoid. Another picture of dermoid. This is an X-ray of dermoid. These are the teeth. So these are the features, radiology features of ovarian tumor. Malignant tumor usually bilateral and benign tumor usually unilateral. And multilocular, malignant tumor usually multilocular and benign tumor unilocular. And thick septa in case of malignancy, I have also mentioned thin in case of benign. And solid component may be present, but in case of benign tumor, intercapsular solid tumor, absent usually. If present papillary growth like present, this will be little amount. And ascites will be present in case of malignancy, absent usually in case of benign tumor. And lymph nodes will be enlarged in case of malignancy, and these are not enlarged in case of benign tumor. Omental caking present, these are the radiological picture, and low resistant high blood flow. That means increased vascularity in case of malignancy. and low flow in case of benign tumor. These are the radiological feature of ovarian tumor. Sometime during examination, this is a question come. How do you differentiate a ovarian tumor, whether it is malignant or benign, during laparotomy? During laparotomy, how do you differentiate whether it is benign or malignant? After opening abdomen, in case of malignancy, hemorrhagic fluid come out, or straw color fluid usually come out in case of malignancy. And ovarian tumor usually bilateral in case of malignancy. And the surface will be ugly looking. There will be engorged blood vessels. There will be multiple deposit over the intestine and on the surface of the diaphragm and peritoneum in case of malignancy. And in case of benign tumor, there will be no ascites usually. Okay, some cases there may be ascites, and there will be smooth walled, well-defined cyst. So you can mention like this. How will you differentiate benign and ovarian tumor after laparotomy? One question may be asked, what are the ovarian tumor markers in case of ovarian tumor? This is an important slide, some teachers' favorite question. This is the favorite question of some teacher. In case of endodermal sinus tumor or yolk sac tumor, alpha fetoprotein is raised. Epithelial ovarian tumor, especially serous C125 is raised. Sertoli Leydig cell tumor, testosterone raised. In the D-germinoma, LDH alkaline phosphatase is raised. And choriocarcinoma, beta SCG is raised. And mucinous tumors, CA19-9 or CEE, carcinoembryonic antigen or CA19-9 is usually raised. And in case of granulosa cell tumor, inhibin raised. In case of ovarian tumor, C125 is usually raised in case of serous tumor, but there are also other conditions in which C125 can be raised. What is the normal value of C125? It is 35 unit per ml. So these are the conditions: pregnancy, menstruation, endometriosis. In case of endometriosis also, C125 is raised. Epithelial ovarian cancer tumors, acute PID, genital tuberculosis, fibroid in case of some case of fibroids, pancreatitis, hepatitis, C125 may be raised. But in case of ovarian tumor, C125 is raised more and more than these cases. And C125 has a prognostic value in ovarian tumor. So up to this, have you any question, dear students? You can ask any questions. So this is up to my today's class. If you have any question, you can ask. Tonusri or any other, can I ask any question? You can unmute yourself and ask question. Or Shafinas, Hassan, do you have any question?
ম্যাম নো ম্যাম ম্যাম বুঝতে পেরেছি ম্যাম, অনেক ভালো হয়েছে।
Okay. This is usually practical class. This will be during corona. you're not going to ward and see patient practically. So I tried to make this class with practical pictures.